With technology, I think we have an opportunity to not only challenge our norms, but also prepare the patient for a better journey. And I just wanted to share this case, and all these cases are actually from UPMC Chartwell, located in Pittsburgh. And this is an SCIG patient, and this patient was actually on service before we initiated the pilot. So let me welcome you to patient MM. And as you can see, she's a 57-year-old female, and she has a primary immune deficiency. She has some other comorbidities. You can see her labs, her IG levels are therapeutic. And we actually inherited this patient based upon a change in her health insurance, our payer, and essentially onboarded her in December of 2022. So with that, the other home infusion company had alerted us that this patient did have some adherence measures or issues that were prominent within the service that they provided. So real quick, right, medication adherence, two things, right? Patient doesn't take the drug or they don't take it the way that they're supposed to take it. That's from our FDA. And then persistence is essentially the first dose to the last dose. Are they taking it per the frequency prescribed? So when we look at different measures, right, we have direct and indirect. We can stand over our patients for every dose, but I'm afraid nobody here has enough nursing to actually do that. Right? But then in addition, we can do things such as serum levels or plasma levels and, essentially get some objective evidence whether or not the patient's taking the medication. From an indirect perspective, right, we have other things like inventory count. A little hard in, SCIG patients because typically 1 to 2 doses, right, we get them up and running and then they're pretty much on their own with, assistance from our clinicians. If they have trouble, they call in. But really from that, it's really self-reporting, right, as far as how the therapy's going. So when we onboard a patient, we actually look at patients for adherence issues, and we will look at things such as gender, age, physical inactivity, do they have any cognition issues, partner status, are they, single, do they have a caregiver in the home, education level, substance abuse, they have other comorbidities, and then on top of that, any non-adherent history. When we looked at this patient, we actually flagged her, obviously, for the non-adherence history, but she obviously has other diseases that are making her therapies a little bit more complex. She does have a history of substance use, and then she is single living in her home. So what happened here, right? When we looked at this patient, we initiated the patient with 2 doses, nurses went out, doses went fine. And then as you can see, the first part of her journey, right, we're calling, we're getting an assessment, things are going well, we dispense the drug, and we do that month after month. Where things start getting a little tricky is when her next IG levels were actually being drawn and when she was going to the physician offices. She starts pushing the visits back, the blood work's not getting drawn. And then that's when she actually started to provide some indication to our clinicians that, she wasn't exactly truthful. Because when we look at the adherence, scores that we were working through, there was really nothing that seemed remarkable as far as what we could tell being blinded to this patient. So essentially what had happened was the patient changed the insurance again, and, we transitioned her off to another provider along with, the information that we collected. And at that point, we got a call one day from the landlord of her apartment building. And essentially he stated, why don't you come and get your drug, right? It was labeled, had her name on it. And when they actually brought it back, you can actually see the picture there. She only took 6 of the 42 doses, which measured $105,000 of drug that she never used. At that time, we had no clue that the patient was doing, and we do a really high-touch service. And I'm willing to bet that, so there are some of your patients in your population are actually doing the same thing. So we actually really challenged ourselves working with the Eitan folks and said, okay, is there a better way of doing this? Because obviously dispensing it and getting it to the home is only half the battle. So we took our first patient. I want to introduce you to PY. He's 61 years old. He has common varying immune deficiency. And this was actually our first patient, and this is our data showing him actually doing weekly infusions of his SCIG. And I do want to alert to you that, okay, the little bell there, that seems a little bit onerous, but with that, when we actually drive into each of these curves, you can see that the bell was only notifying that this patient was actually providing the first syringe at 40 mLs. It would stop, hence the alarm, and then the second one. So we can actually have a very good idea whether or not these patients are providing the appropriate prescribed therapies. And the situation is that if we see patients starting to have problems early on, we could have avoided that whole mess from the first patient and provided, re-education or, work with them further to basically understand why they're not taking their therapy.